Hi there, I'm Pascal Gagné, and I'm very excited today to be presenting on FSD and sexuality. This is a presentation for caregivers and professionals who are interested in how to best respond to challenging behaviors that are often tricky to address, and hopefully this will be useful to prevent, but as well respond to these situations in your everyday life. So I want to start by saying that although it's not always the case, there's a likeliness that individuals with FASD during their lifetime perform inappropriate sexual behavior. And that's what the research says, that there are 45 to 52% of individuals, adults with FASD, that do have inappropriate behaviors. And the rate appears to increase with the over the lifespan, and studies demonstrate the rates of inappropriate sexual behaviors in children ages 6 to 11 at 39%, 42% in adolescents, and up to 65% in adults. So it's something to adult males. So it's something to consider, because even though you might not think it's going to happen, it's very likely to be the case. So you have always to remember that there's a trauma in the brain, and that the root causes of the behaviors are resulting from the brain injury. So although it's tempting sometimes to classify people into good or bad people, in that case with FASD, it's really a brain disability. So the person is not ill-intended or trying to do bad things. It's really a problem of executive functioning skills and adapting functioning skills, sometimes memory issues and confabulation to remember what was appropriate or not, to apply it in a setting or a different one, to be able to deviate from a script and improvise if there's ambiguity. So all of these are, brain competence that neurotypical people don't struggle as much with than people with a disability. And you have to keep in mind that there's this maturity piece because of the developmental age not matching the chronological age. People with FASD are more likely to socialize with people much younger than their age. On top of that, you have to consider addiction and mental health issues, and often a history of abuse and trauma that is related to adoption processes or violence in the home. So there's an article in the Journal of Law and Psychiatry that asked people to rate professionals what the causes of these inappropriate sexual behaviors were. And if you look at the chart, impulsivity comes first because of the reptilian brain. People lack impulse control, and that's a big part of it. And then the developmental immaturity thing is, and social skill deficits, the more important causes of inappropriate sexual behavior, because individuals do not understand consent or emotions that people display on their faces. And in that case, they're not listening to the other person's reactions or signs that this is okay or not okay. So there is currently no research studies specifically evaluating FASD informed sexual offending treatment or relapse prevention strategies. But beginning with an understanding of the individual and tailoring treatment to their specific strengths and needs is likely to be more effective than putting an individual with FASD through a standardized program. So that's really important. That's a very recent study. It means that there's no evidence-based approach to treating those type of repetitive patterns of sexual inappropriate behavior. And in that case, despite claims from professionals that there might be a solution to it, strategies that are tailored to FSD and that take into consideration the individual needs and is more likely to work. And that's something worth stressing, because it really, really has consequences in the way that you approach a situation that is challenging. So a few of these standardized programs that exist are, for instance, cognitive behavioral therapy, which seeks to understand cause and effect. Oftentimes, parents will say that they are um, uncomfortable with that approach because the child or the teenager doesn't necessarily understand cause and consequences, and that is specific to FASD. So it's not that the therapist is not doing good work individually with the person, that they're not building a good rapport and breaking it down. But it just means that the program itself is not necessarily suited for this type of disability. In intervention clinics for sexual offense, therapists and professionals often rely on models like the risk needs and responsibility model, with responsibility often being neglected. And these focus on criminogenic factors rather than non-criminogenic ones. So, for instance, attitudes, having associates, substance abuse, antisocial personality, problem-solving skills, and hostility anger being more likely to indicate, that the behaviors will be repeated. Again, these were criticized with other specialists who said, good lives model are often best suited when you focus on the overall wellness, well-being of the criminals. Then you're improving their life quality, and then you're opening up a window for change. However, when you look at these approaches in practice, and how people apply them, some of them may lead to recidivism. So good life models, for instance, has been criticized for desensitizing criminals so that they're feeling good about the bad things that they do. So inappropriate methods can have adverse effects if they're not based upon evidence. And in the case of sexual offenses, it's really clear that you don't want to encourage a behavior that is, illegal, for instance. Focusing on strengths, is tricky to do because sometimes people think, oh, they're really good at this or at that, and then they remember all the bad things and they can't really put forward the strengths, they forget them. So it's really about framing behavior and be able to think of that behavior as a step forward, positive outcome rather than a bad, bad event. So if someone had sex, for instance, great, but was it good sex? Oh, let's work toward that, so that this experience that wasn't pleasant becomes a pleasant one next time. You're really good at making friends. You had sex with someone in high school, and they got your attention. You got their attention. Sorry. Well, let's work on making good friends, because that person you had sexual intercourse with might not necessarily be your friend, eh? You're eager to grow up and have a family. You want to get pregnant or you want to have children right away, and you don't want to wait until you're older, that you have a job, that you have a house. Well, here's what it means to be a parent. Here's what the responsibilities are. Are you ready for that? You want to try it out, So those are the kind of things that a strength-based approach will look into, rather than dwelling on whatever happened instead. So appropriate interventions will focus, on strategies that acknowledge the diagnosis. They will enable early intervention, and hopefully, the sooner you address these issues, the better the outcomes are. So prevention is really the best way to anticipate these behaviors and put in place safety measures and strategies in order to cope with them. I'd also recommend, dyadic developmental psychotherapy, because it works as a family unit. People, the parents, the kids come in and they're able to share about their experience and reframe situations and manage their expectations. So that's also very useful. Another type of intervention that I'd say is really good would be social stories. They were invented by Carol Gray and more geared toward autism, but I think a good social story is really, really good way to show what a behavior should be. And you ask people to describe the story, and then they reflect on their own experience. But the social story never says, this is what you did wrong. It shows them, here's what's going to happen. What do you think of that? And it's really basic. It's not a good story. It's a story that explains, social conventions. So how to talk to someone, how to be intimate with someone, and you break it down step by step. Other visual techniques, pictograms, or even the saccade process of drawing, processes. You draw step by step and consequences. That's useful as well. In the matter of sexual education, I would always recommend harm reduction approaches, just because it's very difficult to rely on abstinence programs for sexual education. The behavior, because of the impulsivity, it's very likely that they're going to happen. And then it's managing the consequences that really makes a difference. In some situations, a doctor might as well prescribe some medications, so antidepressants, naltrexone, mood stabilizers, or anti-androgens. I'd say to be very careful and be sure that the doctor that you're talking to is aware of FASD, and that they're also considering all the other medications and side effects of that. So inappropriate, and as well, I forgot to say, when you start with drugs, start low and go slow, because people are very likely to have strong reactions or adverse ones. So inappropriate interventions, not taking the disability into account is not a good idea. FSD is very specific, and in that regard, to treat people with FSD as if they didn't have a disability would be counterproductive. So when there's a lack of diagnosis, and we know FSD is underdiagnosed, it's very likely that it's going to be harmful. Disregard FSD symptoms, so every individual with FSD is different. So they all have different strengths and different challenges. So you have to look at the individual's symptoms and how their cognitive abilities are impaired with regard to specific functions. Traumatic interventions as well are not going to be productive. So sequestration is going to cause trauma, a family breakdown if the family is teared apart by situations, if there's incarceration because of the disability. Again, I'd say, it's missing the point. Sometimes you have to because it's safety, but it's not very likely to turn a bad experience into a positive outcome. It's going to turn a bad situation into a worse outcome. So it's always, a matter of balancing safety and prevention, and trying to anticipate with education. Strictly punitive measures such as guilt, crime, or sanction, claiming that sex is a sin, is very unlikely to be useful, just because it doesn't give people the tools to manage situations and to respond to them. It only dwells in the past and not on the future instead. So anticipating difficult situations means that even though the behaviors are not there yet, if you have a younger child or early teen and you've been lucky enough not to witness any challenging behavior, well, you should be ready for that when that happens. So in-person supervision, online supervision, use of technology, make sure that the person is not put in a situation where they're going to fail. So I've had clients in the past, for instance, that were saying, my child is really good with younger child. He could be a great monitor at a summer camp, or he could be babysitting. I'd say, maybe not the best idea. So if that person is supervising someone, who's going to supervise them? You have to keep that in mind. So if they're going online, would you let them watch all the videos they want, surf on all the web pages that you want them to surf, or you would trust them? Well, I'd say, better to put safety measures in place before that. Developmentally appropriate sex education is very important as well. So depending on the developmental maturity of your child or teen, they might not be matching their age. So people might be curious about body parts when they're 14 or 15-year-old, and that's not age appropriate. It's something that should happen technically younger. So if you notice that while talking about sexual report and practices might be a little inappropriate because developmentally the person is not there yet. So you have to consider, body parts, intimate relationships, and then sexual practices to move from this is a penis, this is a vagina, using the terms, being very concrete, very visual, avoiding, as much as possible, abstract concepts. And then you move forward to, this is a good relationship between a guy and a girl, or a guy and a guy, or a girl and a girl, or this is how someone thinks about their sexuality, this is how someone thinks about their gender, and so on and so forth. And then you talk about, like, here's how you have sex, and here's how you use condoms, and here's how you use the pill, and blah, blah, blah. And here's the kind of practices that people say, and that's appropriate and that's not appropriate, blah, blah, blah. So practicing consent and safety measures is really, really crucial, and you're going to repeat yourself quite a bit. So it's not an in and out thing, such as some clinics, professionals offer for, neurotypical people. So you can't assume because you said it once that it's going to be assimilated and remembered. On the contrary, you're going to have to repeat yourself quite a bit and practice, scenarios and role playing, because that's the best way to learn. So saying things is often not enough. You have to enact them to be able to really make sure that this is ingrained in habits. So practicing social scenarios, teach personal space and safety circles. So you can draw, a personal space and visualize it so that person understands, half a meter away from someone, you don't get in their bubble, or safety circles, if the certain body parts are not safe, like you don't touch someone's breast, you don't touch someone's crotch, you will touch their hand if they give you permission, you might touch their head, but it's not really, so green, yellow, and red circles. And finally, I'd say having a safety and emergency card always available on the person, or a medical bracelet. So there was a program for autism that was created by Jamie Dunlap for his own son. He was concerned about police criminalizing young people with autism, and that has been expanded to individuals with FASD. So it's very useful, and I would recommend to join that. So when in the moment, when something, really challenging happens, and it's happening right now. So I'd say as much as you can, try not to shout or to cry, and it's not always easy to do. And the reason for that is because of the mirror effects. So someone with FASD might match the effect that you're displaying, even though they don't understand why. So if they did something and they don't realize why it's a bad thing, or that it's off limits, should I say, the parent or the professional might be really angry, and then they'll respond by being really angry as well. So that doesn't work as well. Never shame, it's, again, brain disability. It's not necessarily something shameful that the person did. It's a counterproductive response. Parents should always remain calm during the intervention, and professionals should be careful not to judge. Needless to say, it's not easy to do, but if you want to move forward and address it and improve the outcomes, this gets in the way. So seek out professional support services immediately after traumatic experiences. So don't don't ignore it. Some people will minimize sexual offense behavior. And that's what we see the most in the literature, is that the parents and the professionals who minimize it, then the person will not, acknowledge their behaviors, and it's going to get worse. So it's really important that if something, challenging occurs, that you don't put your head in the sand. So it's going to be better. And research shows that if it's addressed as such, it's very likely that all will be put into place, responsibility will be taken. There's a cognitive process that will go on within the individual that will move things forward. It's not going to be traumatizing for your whole life. It's going to be actually a healing process. And intervention should be concrete, repeated, and supported or backed up with professional consult or expertise, or clinicians with FASD knowledge. So again, if you're a professional, don't do this on your own. It's very difficult and very challenging, and you want to have a team of people around you. As well, I'd say, it's always good to have multiple people involved, and that there's consensual approaches, because the individual might forget or imagine that things happen differently than they did. So you want to have, at least two people together that when there's an intervention, so that there's a second opinion, there's testimony, and there's also, a team around the person. So here's a couple of very challenging scenarios, and I'm going to go through them because we don't often talk about it, and everyone thinks they won't have to deal with this. And what we've seen at the fetal alcohol resource program and the FASD worker program is that these occur, and when it's the case, it's always best to know what to do. So in that spirit, for caregivers and professionals, I'm here talking about these challenging behaviors that hopefully won't occur, but if they do, you won't be surprised and you'll know what to do. So for instance, Tommy, 15-year-old, has been touching himself during dinner on the table. His parents notice it for the first time when they invited guests over. So what to do? Well, the first thing would be to ask Tommy to come help them in the kitchen to prepare lunch, and then bring him to his bedroom, and then explain the behavior to Tommy, that this is a private behavior and that dinner is a public, situation. And if Tommy has a fixation, accompany him to his room, and check in later so that he can reintegrate the group when he has finished his activity. So Tommy might not understand that the bedroom is private and that the kitchen is public. He might understand that the living room is private if you tell him, but he won't be able to apply it in someone else's living room. So it's very tricky, because that's part of the adaptive skills, adaptive functioning skills that people with FASD often lack. And that's the transferability, or be able to apply in different contexts. So you have to diffuse the attention with the group by explaining that you're teaching Tommy how to behave, and that there are many people around when there are many people around, and that it's part of a learning process because he has a disability. And have a safe word for inappropriate behaviors between parents to manage group dynamics if you see that occurring again. Agree beforehand on who does what when this should occur or could occur. And take time to teach Tommy what to do in public versus private spaces. Again and again, and consult with a trusted occupational therapist. Oftentimes it's a sensory issue. So scenario 2, sexual promiscuity. So Betty, 13-year-old, wants to buy clothes, but she can't afford it. So she has engaged in sexual rapport with strangers in exchange for gifts or money. So in that case, you would sit down with Betty and ask her what she wants, why she needs it, explain when she does these kind of things, what kind of clothes she wants, what kind of intimacy she wants. Explain to Betty that you're there to help her if she wants things that she needs, so that she doesn't need to rely on some stranger to purchase the clothes that she wants or the makeup that she wants. Explain to Betty what a healthy relationship is. Explain to her better, and explain to her safer sex. Repeat a couple of days for, I'd say, at least 6 months. So even more might be needed. Ideally, schedule a time frame in a day to cover these issues. Supervise Betty when she's going outside. So if she's not, if she's mingling with strangers, you would not put her in a situation where she will be soliciting or be solicited by older men. Ask someone other than you to drive Betty where she wants to go if she doesn't want to be with you, so that there's other adults that she can rely on. Purchase a few items Betty wants so that she can trust this person. Make sure Betty has access to birth control and explain health risks related to unprotected sexual report. Teach her about the consequences of prostitution with regards to the law. So make sure she understands what she's doing as a name, and it's called prostitution or solicitation, and that she understands, that there's consequences to that. Involve trusted social workers, police officers, correctional officers, teachers for advice and support. So my scenario 3, fetishism. So Bobby, 20 years old, is stealing his little sister's shoes and masturbates with them. His parents noticed it when the little sister complained about her shoes being wet. So I would say explain boundaries to Bobby and clarify that sex with siblings or your siblings' personal effects is off limit. If Bobby has a fetish and focuses on shoes, purchase him shoes. If he's obsessed with sisters, supervise all sibling interactions and minimize common schedule. Oftentimes, the fetishism is related to some sort of broken relationship when it's not possible. So the object is a way to mediate that relationship. Introduce Bobby to new friends by going to social groups. Bobby's attention must be refocused on something else, or I'd say someone else. Say, and again, consult with a trusted psychotherapist or sexologist. So here, perfect example of why harm reduction approaches are better. It's better to purchase panties or shoes than to remove them and create an adverse reaction where it's going to be more exciting to find them. So scenario 4, incest. So over one morning, you discover that 2 stepbrothers, Andy and Jeremy, are not sleeping in their respective bunk beds. They are sleeping naked, and there's a strong body odor coming from the sheets. So something happened, and you can guess what it is. So I'd say, explain to Andy and Jeremy that they should not be in the same bed, and explain that the family life is intimate, but that sexual intimacy between siblings is off limit. Explain consent, healthy relationships, homosexuality, and safer sex. Inquire about the siblings' understanding of these notions, and if there's pressure from one sibling toward another, or if they were curious to explore these things. And it's kind of part of normal development that people are curious and that they try things. You just want to make sure that they understand that they shouldn't be trying that with each other if they're brothers. So consider having a different layout for the bedrooms and supervise family time and interactions. Consider turning on motion sensors in the room at night, so that to avoid that. So introduce Andy and Jeremy to new friends and social groups. Again, refocusing attention on other people and expanding the circles. So it's often a case where the family is very recluse and there is not that many people in their lives. And if there's not that many people in your life, well, you crave the connection from someone you know. So I'd say consult again with a trusted psychotherapist and sexologist. Consider a history of trauma and sexual abuse, especially in cases of adoption. And depending on the assessment of the situation, you will have to involve the Children's Aid Society and consult your lawyer. So precocious sexuality. You receive a phone call from the school because your recently adopted daughter, Casey, age 8, has engaged in sexual rapport with another friend at school. When confronted about this situation, Casey makes sexual offers to teachers and to you to get out of trouble. So I'd say it's probably the case that she's been abused in her former family, whether she was in foster care or in her biological family. I'd say that Casey needs to understand that she is safe with you, and that's a safety issue. Again, when you talk about adoptive children, it's always safety before love. So it kind of sounds weird, but safety is the first step toward nurturing relationships. Casey's behavior must be addressed through trauma therapy and consult a psychotherapist. Involve social workers and SCS preventively. So they are more than willing to help when they're involved, and they can contribute to improving family dynamics. Explain to Cassie what good sex is, a safe, pleasurable, intimate, and consensual relationship, so that she knows, what to look for, and rebuke every sexual events explicitly. It's self-evident. Explain that the behavior is inappropriate. Don't neglect it. Don't redirect it. Make it a teaching moment. Insist on safety and how you can address her needs. Engage the dialogue with the school to ensure that all students are safe. So you want to make sure that not only her, but everyone else in the school will be. So scenario 6, Mandy, age 20, is very curious about other bodies. She plays peekaboo and peeps under the bathroom stalls at the public library. So again, provide more information about body parts to Mandy. If prompted, explain similarities or differences between bodies depending on the questions asked. Explain appropriate versus inappropriate spaces to be naked in. Explain that people do not like to be seen naked unless they consent. Some do, but you can assume that. Explain consent as well. You want to repeat that with Mandy, and you want to practice again in different settings, appropriate or inappropriate. And if you repeat it in different settings enough, it should be acquired and transferable. So make sure that you practice it. So everywhere that there's a potential for boundary breach. Scenario 7, pedophilia. So Martin, age 28, has been babysitting his neighbor's daughters, age 7 and 8. One day the parents come in and they find him naked with the children. So that's a challenging one, needless to say, and that's very difficult to manage. So police intervention is required, so call the police right away. He should not be allowed with children without supervision. So he's probably been put in a situation where he was going to fail. And unfortunately, Martin was not supervised, so he couldn't know better what to do. He should receive developmentally appropriate sexual education so that he knows. He was maybe just curious about body parts, and was curious about what it looked like with the children. So that's to consider. Martin should join relevant peer support groups and learn how to practice social skills with age-appropriate individuals. One of the ways to do it is to make sure that the individual only has sex with people their age or older, and again, that they ask for consent before having sexual intercourse. So David Boulding, for instance, said that the rules for sex were to always say consent, state consent out loud, and that way you avoid any quid pro quo. The neighbor's entire family should engage in therapy sessions, needless to say. So scenario 8, child pornography. Elizabeth notices on her iCloud that her daughter, Emily, age 12, sent out nude pictures to her classmate. So that's very likely to occur. I think most people have been surprised with what they found on their iCloud during COVID, being stuck at home, and it's something that's happening for people with or without a developmental disability. I'd say Elizabeth will grant Emily's access to her phone only with supervision. She may also consider to give her access to a phone that doesn't have a camera feature. So either a flip phone. I have a colleague of mine who recommended that the mother break the camera on her child's smartphone. So there's plenty of ways of doing it. I think you can disable it as well. Elizabeth will destroy the pictures on her iCloud. She will not put parental restriction on the website. But again, I'd say consult with an internet safety expert, because some of them have been advising the opposite. So in any chance, if you have a doubt, call an expert for that. Elizabeth will investigate to whom the picture went, and will talk to the other party's parents if they are minor, and they will call the police if they are an adult, which is why you want to know if that happens. So you don't want to turn a blind eye. It's better to see it and to be forgiving. Parents often get caught in the midst of action as well, so you have to forgive when your child or teenager is learning how to do it well. Scenario 9, luring a child online. So Joseph, age 19, has been spending all day long on internet forums. His parents find out that he solicits naked pictures of young children, aged 11, 12, and does video chat with them. So Joseph will not be granted access to his computer, smartphone, tablet, or any wireless device without supervision. His parents would put parental restrictions on specific websites, add timers to control when he can access the internet. For instance, during a window of 3 p.m. to 5 p.m. And they may call the internet providers, their internet provider for support. They may call as well as specialized IT consultants or internet safety experts, and they will get the police involved proactively. So they will build a relationship with the police officers, especially if they're worried about their child not understanding the law, and then the intervention with the police, in any situation that I've described above, will be, a good teaching moment rather than a traumatic experience leading to worse outcomes. So Annabelle, age 16, is fighting with her parents. She has no friends. One day she befriends a stranger on social media. He invites her over and she claims to be in an intimate relationship with him. After a week, she does not want to return home. Well, it's very likely that Annabelle is being recruited by street gangs for human trafficking or for home invasion. And I would insist that Annabelle returns home. It would be a very, very good idea to call the CS and the police. Even though she's 16, they may be involved, and the police as well as a prevention. There's some specialized programs. For instance, there's Ottawa Crime Prevention in Ottawa, and work with the specialized task force to prevent human trafficking or home invasion. So if the individual is not willing to collaborate because she's 16, she has rights and she can refuse to come home. In most cases of home invasion, the individual cannot refuse because they think that the person is their friend or their family, and they really struggle to say no. Same with human trafficking. People get attention and flattery, and then they feel good about themselves. They lack self-esteem, and that's what the trafficker provides to them, that boost in self-esteem. So there's a bunch of resources out there. I won't put them all, but there's the teachingsexualhealth.ca website, Safe Sex and Fun booklet and video that I like for people with intellectual disabilities. Explains very clearly how to do consent, how consent works. There's another video, Consentee, but again, any video that is too abstract or relies on metaphors will not be understood by someone with FASD. It needs to be really concrete, and it needs to be not a banana with a condom, but a penis, a picture of a penis or a drawing of a penis, but something very explicit. There's someone, for instance, that a friend of mine worked with, and the person said, "Mom, I'll carry a condom in my pocket if something happens." And the mom was like, "Always carry the condom in your pocket. Always carry the condom in your pocket." And he came back home one day and he was very happy. And the mom knew right away something happened. And she said, "Well, did you use a condom?" "Of course, no. I kept it in my pocket." Right? So you want to avoid that. There's another guide that I like quite a bit, Healthy Bodies, Safer Sex booklet for trans and non-binary people. There's many resources, whether they are pictograms or social stories online. You can use apps for that. I'd say don't be afraid to create your own tools and adapt them. Make sure that you don't point out that it's the individual's behaviors, but that it's a social story or like an example of what to do. And people will be curious. They will want to learn, and they will be asking questions, and no question is off limit. You want to make sure that the person asks you for advice, that they turn toward you or another adult that they trust, that if they need condom or any lube, that there is some available in the house. And finally, I'd say consider preemptive measures such as going on pills or any other contraceptives. As a selected reference list, please look at these below. And if you have any questions about sexuality, make sure that you consult with specialists, either your FASD worker or people who are knowledgeable about FASD. Thank you so much for listening today.